I spent the last month in Bangladesh. One of the difficulties coming back from Bangladesh is the difficulty of taking any problem in Canada seriously. We are such a privileged country. I walked from my brother's home across the bridge, the Broadway Bridge, and this is an idyllic prairie autumn day. No wind. The postcard sight of Vesper reflected in the river, the ducks playing happily, and healthcare costs was the last thing on anybody's mind as they either cycled, walked, drove to work, or looked at the ducks as I was doing. I'm going to make the pitch for benign despots and their necessity if the system's to survive. I will go to the first slide. I stake my commitment to a single-payer health insurance system, for which there are many, many equity and efficiency arguments. But what at the heart you're doing as you move from a market to a single-payer system is that you're requiring political authorities to make decisions. And there's no decisions more painful than those that bear on life and death. And in Canada, we've not been very good at the last 15 years. Here's one of my favorite quick slides. It shows the annual percent change in provincial public health spending. This is just nominal dollars. And I can sum up 4 decades in drift, fiscal crisis, drift, in the sense that in the period prior to the mid-1990s, 1983 to 92, there was an annual percent growth of 8.4%. Then we had essentially no growth for 5 years. And then we went back to unsustainable rates of growth. Slightly less, admittedly, in the last couple of years, but far too soon to know whether we're going to get out of this. This is not sustainable, as is. What I'm first going to do here, and this was to satisfy my own intellectual curiosity in some sense, is my own coming to grips with trying to think through the implications of my generation becoming old, decrepit, and making very large demands on the health system. Canada is still a relatively young country. Here are the G8 countries showing the proportion of the population 65% and over, and Canada is about 15%. 2011 is much higher than it was in 2006. But the country is now aging quite quickly. What this shows is age cohorts of approximately 5 years each, and the percent change in those age cohorts between the 2006 and 2011 census. And this is a figure that I just ripped off Statistics Canada, and the point to be made here is that all of the cohorts over age 50 are growing at something like 2 to 3 times the rate of those under, and 2 to 3 times the overall average. The aging process is not even across the country. If you take the extremes, the proportion over age 65 is 50% higher in Nova Scotia than it is in Alberta. And given the age, specific components of healthcare costs, that obviously has very serious implications for the above average provinces. While another component of this, which we tend not to talk about as much, is the fact that the aging of the population has the impact of reducing the active share of the population in the working age. And it's not mathematically inevitable that as the over 65 increases, the 15, or in this case 15 to 64 share rises, but there's a very high correlation that it do. Hence, for the provinces, there's a problem of those that have high over 65 share typically also have less than average working age population share. So a very simple projection that a colleague in the C.D. Howe Institute and I did. I will unpack the assumptions for you a bit so that hopefully it makes some sense. The key idea that we worked with was some idea of intensity of service per capita, abstracting from the change in the population distribution what has been happening to expenditures per capita. And then you can superimpose on that what are projected changes in the population distribution. So over the years 1998 to 2009, taking out the effect of changing in the population distribution, in real terms, we were increasing public spending across Canada by an average of 2.3% per year. The future rate of the growth intensity is something which I'm going to use as a parameter. Population projections. This exercise goes forward to 2050. I'm not sure if I believe anything beyond, say, 2030, but we assumed very orthodox parameters: 1.5 fertility rate, life expectancy rising in StatCan normal manner, number and age distribution of international migrants remain unchanged. We made the assumption, a very simple one, that the rate of growth of productivity per person in the active age population would grow at the same rate that it has for the last 15 years. And then comes this, the key metric that I'm going to talk about very briefly, is what is the overall public spending relative to GDP. And aging has two effects. One, it increases the average spending per person because you're dealing with a population that is older and has higher health requirements. And second, it lowers what would otherwise be the rate of growth of the GDP because you have a smaller share of the population in the active working age cohorts. So, I keep going. Here's something that will not happen. If we carry on with the projections that I did in terms of population, and we carry on with the same average intensity increase per capita, we get by 2050 that we have increased the share of GDP spent by the provinces from something in the order of 8% to something in the order of 20%. That's simply not going to happen. If we do, and that, I won't spend any time on that for reasons of time, I won't go through that slide. Let me do a next exercise in which we reduce the rate of growth of intensity of service by half. Over the years 1998 to 2009, it grew by roughly 2.3% in real terms per year. Let's cut that in half. Then what happens? And that means a much more manageable increase in provincial public health costs as a share of GDP. And if you then look at it in terms of, I've been given the 10-minute note, now I want that taken away from the screen so I can see what the hell I'm talking about. I've gone and I have tried to think about this in terms of what would happen if we did not age. The red line is hypothetically what happens with the age projections and the productivity projections and various other things which I've tried to be fairly honest about, but probably I've not unpacked to your satisfaction. The green line is what happens if magically there was no change in the population distribution with respect to age. And you get a line which is, not surprisingly, much lower. And the gap between them is something that at a first instant you can attribute to population aging. So the population aging dynamic, and let's just stick to the 2030 data because I don't really believe anything in 2050 as a projection. If we assume this scenario where we reduce the rate of growth of intensity of service by 50%, we are implying that relative to a no aging scenario, we're talking about a 3.6 percentage point increase in health spending as a share of GDP. Roughly 2/3 of that is attributable to the fact that an aging population has higher health spending. Roughly 1/3 of it is due to the fact that we have a lower rate of growth of GDP than we would if we didn't age, because a smaller share of the population in 2030 is going to be in the active labor force. If we go now to a much more drastic scenario, which is the third, that implies that we almost eliminate any rate of growth of intensity of service, keep it down to 10%. That results in a very modest increase in the spending, public spending as a share of GDP. It rises from about 8 to 10%. I'll happily share these with you. I don't think it's worthwhile my going through much of it. This is the analogous exercise in allocating that increase either to aging or to decline in GDP. And in the final 5 minutes or so that I've got left here, I feel some obligation to say what the hell to do about it. And I bow to you as people with practical ideas. I have some very small toehold on reality in as much as I've been the treasurer of a community health clinic in East Vancouver for the last 25 years, and we've managed to balance the budgets in most years. My first observation is there is some tax room. And this is a rather simplified graph that I've thrown up here of government tax plus non-tax revenues as share of GDP for the last essentially 2 decades. And Canada has gone, which is the light blue line, from being in the second quartile as a relatively heavy taxer, until in the last 4 or 5 years we've been a low taxer. We're coming down, we're in the third quartile, and we could increase our tax to GDP take. And also significant here is that relative to the early 1990s, we have significantly reduced the tax wedge relative to the Americans. So there is less problem than we had 15, 20 years ago when Dan was trying to balance the books, Greg, here in Saskatchewan. We don't have quite the same pressures as we did before. So there is some tax room. But my final graph is a pessimistic one. Probably we will undertake some tax increase relative to GDP in the next decade as a means of accommodating the boomers' implications for healthcare and accommodating technology change. Second, I would very much like, and I think it very unlikely, that the public discourse start concentrating much more seriously on the idea of what is the public spending, the intensity of service, and some constraint on that. Inevitably, it's arbitrary. I mean, all of you can think of good ways to spend an extra 1 million, 10 million, 100 million, depending upon which part of the health system you are operating in. Inevitably, that's not the way the health budgets are going to be constructed. They are not going to be built up from all of the good ideas starting at the bottom and going up to the top. Inevitably, there are going to be a lot of political dynamics which have only tangentially to bear on the health system, which are going to decide. I very much hope that the senior officials, the deputy ministers, the director of health regions, the health ministers are making these decisions in a benign manner. But there's going to have to be a despotic aspect to this. If we're going to preserve what I very much value, a single-payer health system, it has got to live within some fiscal constraints, which in the last 15 years it has not been living within. If we don't live within those constraints, my fear is we repeat the scenario of the mid-1990s. The period of the 10 years prior to the 1990s were somewhat similar to the decade we've gone through, namely fiscal drift with respect to health care, and then all of a sudden doing the fiscal crisis and fiscal adjustments in a context of panic. And nowhere was that panic more intense than here in Saskatchewan. And I personally know a number of the people intimately involved in making those decisions. By and large, the Saskatchewan tradition of benign despotism in terms of health managers got us through in a reasonably good way. There were mistakes made. To give credit where it's due, Lucien Bouchard tackled in the context of Quebec many of these problems when, in the late 1990s, he was premier. In a recent interview in Actualité, he was asked, what was, as premier, the most important thing you managed to accomplish? His answer, in a context of incredible pressures and difficulty, we managed to balance the Quebec budget. And then a subsequent question from Actualité, which, by the way, is the Quebec equivalent of Maclean's magazine, what was the worst decision you made? And he pondered and replied, firing nurses. That in the context of the fiscal crisis, not only in Quebec, but across Canada, programs were put in place to try and reduce manpower, or person power, if we're trying to be politically correct, and we got rid across Canada of a vast number of very skilled nurses, crucial to the running of the health system. We don't want to do that again. But if we're going to avoid going into, at some point, crisis mode, I argue that we very much have got to get a control on the rate of growth of intensity of service spending by the public sector. Now, very much tongue-in-cheek, Bill Robson, with whom I have had friendly sparring debates about public policy for nigh on 2 decades, he wrote a piece on this subject in which, tongue-in-cheek, he drew the parallel with the Canada Pension Plan. Another interesting piece of social policy designed with parameters in the 1960s with respect to productivity growth, fertility rates, that proved by the 1990s to be completely untenable. Had we not, as part of the fiscal crisis of the 1990s, effectively doubled the so-called contribution that we all make annually via the Canada Pension Plan, or Quebec Pension Plan in the case of Quebec, we would by now be running the Canada Pension Plan effectively as a second old age security system, pay-as-you-go, with negligible link to earnings. We didn't do that. We forced my generation to start pre-funding in a more adequate manner than we had been up until the mid-1990s, our expectations of receiving Canada Pension Plan payments in our old age. Bill said, tongue-in-cheek, why don't we do the same thing in healthcare? So of my 3 recommendations, tax to GDP increase, probable. Paying serious attention in the political dialogue about healthcare funding to the rate of growth of service intensity, independent of the change in the age distribution, unlikely. And Bill Robson's idea that we're going to handle the healthcare problem in the same way as we handle the Canada Pension Plan, highly unlikely. And with that, I thank you all very much for having listened, and I look forward to the Q&A.